after. So our next speaker is Michael Kidd. He's the Chief Medical Officer for Australia. He's obviously based in the Australian Government Department of Health in Canberra. He's a general practitioner in primary care and public health researcher and has served as President of the Royal Australian College of General Practitioners and President of the World Organisation of Family Doctors. So it's my pleasure to introduce Michael, who's going to speak on National Immunisation Strategy 2025 to 30, Tackling Winter Infection, Focuses and Measures of Successes. Thank you, Michael.
Good morning, everybody, and thank you for the opportunity to speak today at the 10th Annual Immunisation Forum here at the Marvel Stadium. I have to tell you, my great nieces and nephews are very impressed that today I am performing at the Marvel Stadium. I would also like to start by acknowledging the traditional owners of the lands and waters where we're meeting today, the Wurundjeri and the Wurrung people of the Kulin Nation. Pay our respects to the elders past, present and emerging, and extend those respects to all First Nations people here today. This is the reconciliation artwork for the Australian Government Department of Health, Disability and Ageing, and I love it. It has this beautiful combination of traditional Aboriginal modalities of healing with plants and animals, and mixed in there are little motifs of Western medicine. And can you see the syringe sitting in there? If I had a prize, there'd be a prize for the first person to see it. I'm now 12 months into the role of being Australia's Chief Medical Officer. I've just passed the 12-month point. It feels like 12 weeks. Every week is different. Some of you may recall that in the first couple of days after being appointed as the Chief Medical Officer, I spoke at the 9th Immunisation Forum over in Adelaide. It was the very first presentation that I did in public, and I was very pleased to do that because vaccination is so important to protecting the health and well-being of the people of our country and people all around the world. Today I'm going to focus on how our national immunisation strategy positions us to better tackle winter infections, and particularly just remind you about what's already underway, what's changing in practice, and how we're going to measure success. And ultimately, this is all about ensuring that our healthcare system is ready and responsive to deal with the challenges that we face each and every winter. I would like to thank Alicia Carisi, Danielle Howson and Dave McNally and other colleagues from the Department of Health for preparing the slides for me. So let's start by having a look at what we know about the current barriers and challenges to the uptake of winter vaccines. As you all know, as well as I do, winter infections remain one of the most consistent pressures on our healthcare system. We're seeing several persistent challenges in consumer perceptions and attitudes, and ultimately this has led to a lower uptake of influenza and other winter vaccines than we would like to see. From the National Vaccination Insights Project, some key observations reported here are that there is a perception among many consumers that influenza is mild and unlikely to affect them and the members of their families. There are ongoing concerns about the safety and effectiveness of the COVID-19 and influenza vaccines, particularly in the post-pandemic era. Many people don't prioritise influenza vaccination for themselves or their children rather than actively refusing it. And there are practical barriers. You have to find the time, you have to make a booking, there's the convenience of where you can get access. These all matter, even if they're not as dominant as some of the attitudinal factors. The implication of all of this is that we need to make vaccination easy, expected and timely, especially ahead of winter. So in response to those challenges, Australia's National Immunisation Strategy sets a focus for us for the next 5 years. The national strategy is our framework to reduce the impact of vaccine preventable diseases by lifting levels of coverage. And importantly, it's not a funding plan. It's not intended to replace existing programs or existing investments, but instead it gives us a clear vision and mission and identifies these 6 nationally agreed priority areas which cover access and equity. They cover trust and data and workforce and technology and the governance of our vaccination programs. And together these priorities reflect where our coordinated effort is most needed across the immunisation system over coming years. Now, for immunisation delivery and sector partners, and many of you are taking part in this forum, it provides us with some national direction, but it also allows for flexibility as to how that's translated at the local level. In the first year, we've been building strong foundations to ensure the strategy can be implemented effectively. And for winter infections, this matters because we're not just responding each season. What we're doing is building ongoing readiness across the system, across years. Which brings us back to our goal of ensuring a system where vaccination is easy and expected and supported, especially ahead of the winter peaks. This then links directly to our National Immunisation Strategy Implementation Plan, how we're translating the strategy into action. And this has been developed and has a number of components which include a framework for implementation and also the Commonwealth's action plan, which describes the specific advanced initiatives in each priority area. The plan's intended to be living and iterative and will be updated at least every year. Now, to respond to current challenges, I just want to highlight that there is already substantial national activity underway, many of you are leading that, to improve access and uptake of immunisations. And I want to pay tribute to all of you, to Aditi and to all our colleagues at NCS, to Jim and all the people who are working with you, to everybody here in the room. You're all part of this. Outlined here are some of these activities. You'll see at the systems level, we're strengthening the policy and data and delivering systems. That includes a really important change to the Aged Care Act from November of last year, which now requires that aged care providers ensure access to influenza, COVID-19, pneumococcal and shingles vaccines for every resident and for their staff. We've also taken targeted responses with priority groups and working with those groups to strengthen the approach to support older Australians in aged care, dedicated funding to address culturally specific barriers for First Nations communities, and co-designed work to strengthen the maternal vaccination pathways, and we've been hearing about some of that earlier. And alongside that, there's communications and practical support tools, which include our national campaigns, resources shared with providers, catch-up calculators, reminder systems, and work through our primary health networks to help translate the policy into delivery on the ground. I recently wrote to all my colleagues in general practice about the key role that Australia's general practitioners and the nurses working in general practices play in addressing vaccination hesitancy, in providing trusted advice to the people who trust them for their health care and advice for themselves and their families, and also the opportunistic chances for providing vaccination when people present for other reasons. The Australian Government Department of Health, Disability and Ageing currently has 3 communication campaigns in market, and I hope that you've seen some of these. It includes a new winter vaccinations campaign for older people, focusing on influenza, COVID-19 and RSV vaccinations, and that campaign educates people about the severity and risks of these viruses and the benefits of vaccination to prevent serious illness in those in older age groups. Also, we have new phases of the childhood campaign and the maternal vaccination campaign. All those campaigns were launched in the middle of April. They'll run to the end of June. And they include not just traditional and digital media, but online partnerships, social media, community engagement through a number of activities. And for the healthcare professionals and sector partners here at the meeting today, again, you all play a key role in amplifying those messages within your organisations, within your clinical settings. And again, I thank you for your work on that. Here's a flavour of some of our campaign resources which are currently out there. All these resources are available at health.gov.au. My favourite one is the one down the corner there. You can see the older woman who's just had her vaccination. She's now exercising in a swimming pool, and we all know where that Band-Aid on her arm is going to end up, don't we? So we're also strengthening the national immunisation program, and Aditi mentioned some of the elements of this to support winter responses and readiness for future seasons. And I especially pay tribute to the members of ATAGI, Australia's Technical Advisory Group on Immunisation. Some of you are here today for the work that you've been doing on this. For RSV, we've already heard about from 15th of May, the eligibility for RSV vaccines was extended to adults aged 75 and over and to Aboriginal and Torres Strait Islander people aged 60 and over. And those cohorts of people are eligible to receive the newly listed Arexvy vaccine for free under the program. And uptake of the program has been strong, with over 250,000 doses administered to those cohorts in the first 2 weeks of that program alone. Secondly, changes to the pneumococcal schedule. These come into play on the 1st of July, and the existing 2 vaccines are being replaced with the single Capvaxive product. And eligibility for those groups has been expanded to include younger people. And that includes people aged 65 and above, and I am looking forward in 2 weeks to going and getting my pneumococcal vaccine as a person aged 65 and above, and I hope those of you who are in my age cohort are going to do the same. Finally, with COVID-19 vaccines, from the 1st of October, those vaccines will transition to the National Immunisation Program. They'll be available to select groups, and you can expect there'll be a phased approach to the release of communications about the COVID-19 vaccines over the coming few months. But in the meantime, just advise you to continue recommending and administering the COVID-19 vaccines as you have been until we reach that transition point on the 1st of October. Collectively, these programs expand protection, they simplify delivery, and they reduce the burden on providers. Moving towards what's coming up in the next financial year, we have some multi-year measures that were successfully supported in this year's federal budget and were announced last month. And I just want to share with you 3 of these measures, which comprise an additional $41 million package into strengthening delivery of our national immunisation program. First, under access, there's funding provided to expand the NIP vaccinations in pharmacy program, and this will remove out-of-pocket costs for parents for vaccines administered in pharmacy settings to children under the age of 5 years. That funding will be available for payments to eligible pharmacies in those states and territories where legislation permits vaccination in pharmacy to the under 5-year age group. Under the second program there's funding to enhance the National Childhood Immunisation Campaign to tackle misinformation and deliberate disinformation and to rebuild confidence in vaccines, particularly among the parents and carers of children aged under the age of 5. And this funding won't just support reruns of existing campaigns, it'll be new materials and new strategies developed with many of you to better address the barriers and hesitancy and to build on the excellent research which many of you have been carrying out to provide the evidence base. That campaign will be informed by your advice and previous evaluations as well. Finally, there's funding to implement SMS reminders for parents and carers when childhood vaccinations are overdue. so that people know it's time to take their little one along and get their further vaccines. It was a difficult budget this year, and we are fortunate to have secured this funding for these activities among many competing priorities. And I just want to note, though, that through the annual progress monitoring under the National Immunisation Strategy, there will be further opportunities to make a case to government for further financial support as more and more needs are identified. And this is really where your feedback is so important. To bring your experience, and particularly your experience on the ground, into ensuring the success of these programs. Which brings me to the last component about how do we measure success. Earlier this year, we finalised and published our Monitoring, Evaluation and Learning Framework in partnership with the new Australian Centre for Disease Control, the Australian CDC, which commenced operations on the 1st of January this year. And this document sets out how we're going to track progress, how we're going to assess impact, and how we're going to support ongoing learning across the life of our national strategy. And again, many of you are contributing towards the content of the framework, and look forward to continuing to work with you on that important work, looking at implementing the plans, looking at coverage rates across age groups and priority populations, looking at equitable access to vaccines, particularly for priority populations, looking at continuing to build the trust and confidence of the people of Australia in our national immunisation program, and looking to monitor and better understand the incidence and prevalence of vaccine-preventable diseases, both here in Australia and around the world. And of course, what's happening in other parts of the world has an impact on what happens here as well. To wrap up, I did want to say a final word about diphtheria. On the 22nd of May, I declared diphtheria as being a communicable disease incident of national significance. It's only the 5th time in the last 6 years that we've had a CDIN's declaration, communicable disease incident of national significance. The other 4 were COVID-19 in 2020, Mpox, Japanese encephalitis, and syphilis, in response to the continuing rise in rates of congenital syphilis in Australia. We are currently experiencing the most significant outbreak of diphtheria in Australia since we started with national records, which is 30 years ago, but it's probably the most significant outbreak in nearly 80 years. 2/3 of the cases we're seeing are cutaneous diphtheria, 1/3 respiratory diphtheria. The population most affected are people living in remote Aboriginal Torres Strait Islander communities, particularly across the Northern Territory, in the north of Western Australia, but also in the Pilbara and Goldfields regions, and in the north of South Australia in the APY lands. Fortunately, these are communities which have high rates of completion of childhood immunisation for diphtheria, thanks to the extraordinary work of our network of Aboriginal community-controlled health services across those regions. Many of the cases, though, have been detected in adults, particularly in young adults, where immunity is waning. And so in response to the CDIN's declaration, there is a lot of work going into working with those communities to supply vaccinations, initial courses for children who have missed out, booster vaccinations for those who haven't had a booster in the last 5 years, and also a lot of work on identifying cases, treating cases, and also treating contacts, and ongoing support for those communities. Again, I want to thank those of you who've been involved with the response to the diphtheria outbreak. It's alarming to see a disease like diphtheria making a resurgence in a country like Australia. We are, of course, seeing other communicable diseases hit the headlines. We've had the hantavirus experience. We still have people in quarantine in Western Australia who are on the cruise ship, and we have the terrible outbreak of Ebola affecting communities, particularly in the north of the Democratic Republic of Congo, and we've been re-strengthening our own responses in case we have the experience of a case of Ebola or more cases occurring in Australia. Just to wrap up, our immunisation programs in Australia are strong because of collective efforts, and everyone here today, from those of you who are providers, to those of you who are doing research in our world-leading academic centres, to those of you who are advocates from across the centre, everyone here is important in ensuring that our national policy translates into local impact and ultimate protection for the people of our nation. So again, I finish in thanking each and every one of you for your commitment, but also I thank you for inviting me to be here with you today. Thank you all. Q&A.
Good, thank you for such a great overview, such a great talk. Are there any questions, please? Yeah.
Angela Newbound, I'm Immunisation Coalition member and registered nurse and immunisation education consultant in South Australia. Thank you very much for the talk, and thank you very much for the support that's given to this very valuable program. Thank you for the opportunity for some feedback, which I will take. I just wondered, particularly with the winter wellness for older Australians, there seems to be a bit of a missed opportunity because our local council immunisation nurses who have capacity and the appetite to vaccinate adults, unfortunately not 1 cent of funding is available for that adult vaccination program in local councils. And so that would be a fantastic avenue to have more providers who are there on the ground offering adult vaccination. And just with communication strategies, I did notice a lovely advertisement on the television last night of a young child getting a vaccine with the Band-Aid coming onto the anterior lateral thigh of an older child. And I just wondered whether or not there could be some, correct photographs and some correct footage that maybe the deltoid might have been the preferred site. So thank you.
Great insight, thank you. I noticed one Band-Aid, but not that one. And thank you, we'll provide that feedback. That's great, thank you.
Thank you for your talk, Professor Kidd, and for your advocacy for immunisation, which is obviously very important. We have enormously successful programs in paediatrics. Despite the fact that there's been a decrease, we're still talking 92% plus. There is one gap in that, and that's influenza. We have a very well publicised schedule that says at 6 weeks you get this, at 4 months you get this, and so on. We have another thing that says flu vaccine is free, but it's just not part of the schedule we teach people. The IC has for a while been trying to lobby for that schedule to change to include influenza, so that when you turn up at 6 months, you actually get flu as part of your routine 6 months, or if it's preferable, you get that at 6 months in winter, and at 12 months you get it in winter if it was December when you turned up at 6 months. I think it would make a big difference to the amount of people who get influenza, because we all of a sudden treat this as this is something that we should discuss with people, and it seems to be part of the fact that we're getting a 1 in 5 success rate as far as vaccinating. So I'd be interested in whether or not you could lobby for this to actually become part of the table we give everybody else. And secondly, we do really badly with old people. I'm pleased that you're 41 million focused on children moving forward, but having, reached an older age, possibly older than you, I'd be very keen to look to having something similar produced for older people, so that instead of this mismatch of what's funded, what's not funded, whether it's 75, 65 or whatever, that we actually have a similar schedule for old people that says this is when you should get these 6 vaccines and how often. So if you could present that at next year's forum, then I'd be delighted. Thank you.
No, thank you, Paul. Really, really good points. And as an older person, you know, as soon as I could, I fronted up and got my shingles vaccine, which was terrific, and waiting for the pneumococcus. Didn't even think about getting a booster for diphtheria, tetanus and pertussis, because the schedule isn't there and obvious to us. And if I didn't think about it, a lot of other people are not going to think about it either. So thank you, really good points.
Hi, my name's Linda. I'm a nurse in general practice. Sorry, okay. Hi, Professor Kidd. Thank you for your talk. It was fabulous. I think this is a good opportunity as a nurse immuniser in general practice. We do a lot of vaccinating, and obviously that's accounted for. Pharmacists do a lot of vaccinating, and they've received funding now that they're able to give it through the NIP. And still, frustratingly, us nurses still have to include the GPs in the process, where GPs are overloaded and are interrupted every time we need to call them. We're an independent force, and it would be an amazing opportunity that we could actually fulfil that role. So that would be great to be addressed as well.
Thank you. And a huge shout out to the nurses working in general practices across Australia, working in pharmacies across Australia, working in those council settings across Australia. It's the nurses who are administering most of those vaccines. So thank you to you. Thank you to all your colleagues as well.
John Litt, retired academic GP and public health physician, and a member of the Immunisation Coalition Scientific Advisory Group. Michael, it was a lovely, very succinct talk. One of the issues that doesn't get discussed, because clinicians don't tend to focus on it, is that the way that we calculate cost effectiveness is flawed. And so we apply a discount rate so everybody can understand, if I was given $100,000 today, or I was given it 10 years, when will I take it? And so the health economists discount that. Australia is an outlier with all other countries in the world, and that has a big impact on the calculation of cost effectiveness. We put it at 5%. That's been well summarised by Tolly Newell and a number of other groups in vaccine in the last sort of month. And Medicines Australia actually made a submission when the inquiry into the discount rate was coming. So it's been going for 4 years, and it's problematic. A lot of the European countries use 1.5%, a number of others use 3%. Just picking up what Paul Van Binder said, a lot of the vaccines in older people, like RSV vaccine over the age of 65, would be cost effective if you actually adopted a more realistic discount rate. The other issue that obfuscates that is that you actually look at the threshold for quality adjusted life years and what the PBAC accept as a threshold for that. And the rate applied to vaccines is much more rigorous than other medications. So vaccines actually have their hands tied behind their back. So my question to you is, it's a great implementation report, but we actually need to do something specifically about cost effectiveness to make it realistic so that these vaccines can actually get onto the NIP, and we've already heard from Aditi how that can have an impact on coverage.
Thanks, John. And it may be helpful at next year's forum to also invite the chair of the Pharmaceutical Benefits Advisory Committee to come and have a chat about some of the decision making that goes behind what gets onto the National Immunisation Program and what doesn't.
Hi, Michael. Oh, hello. I'm close like a singer. My name's Anna. I'm the Pharmaceutical Society of Australia's National Vaccination Ambassador. So apart from dealing with all the pharmacists all year, the other thing that I have spent far too much time in is the new Aged Care Act and the strengthened standards. And love that RSV's being put on the NIP, but obviously it's not written into the rules yet. So obviously, when I'm having these conversations with the aged care providers, they're already stretched, and I'm doing an RSV tour at the moment, is what I call it, around all my nursing homes. But for those where it's not mandatory or written into the rules, that's going to be a barrier. So I guess my question is there any opportunity, or is that being looked at to have RSV written into the rules?
Yeah, so thanks, Anna, and thanks for the work you're doing as an ambassador. I think everyone in the room is an ambassador when it comes to vaccination, otherwise you wouldn't be here, so thank you. Really, really good point, and it's one of the important elements of the national immunisation strategy that we've got is it's not fixed and static. It has that flexibility built into it so that we can continue to add to all the elements as more evidence comes available, and as you rightly point out, as more vaccines become available through the program. So thank you.
Hi, Mary Ann Williamson, the South Australian West Coast Aboriginal Community Controlled Health Network. We're a consortium of 5 archers on the west coast of South Australia. Really pleased to hear the diphtheria being addressed. I've got to say, over the last 3 days at the immunisation conference, it certainly wasn't very high on the agenda. And, you know, that it's been announced as a significant disease on the 22nd of May, it certainly needs to be on everyone's radar. So in South Australia, over the last few months, I've been vaccinating a lot of people from the age of 10 upwards if they haven't had a diphtheria vaccine in the last 5 years. And I just encourage everyone to use this opportunity, if you are working for Aboriginal people, to actually opportunistically give other vaccines at the same time. Pneumococcal, flu, Shingrix. There's probably one person out of 400 people that I've vaccinated that I didn't have to give any vaccines at all to. So it's really important. And also when you said about treating diphtheria, as we know 2/3 of these are cutaneous sores, and when I did a bit of a scoping of our nurses and Aboriginal health practitioners, how would they dress these wounds? Everyone would do it differently. It's really important that we have protocols in place to dress these wounds if they present, because minimising cross-infection of diphtheria is really important. Vaccination is very important, but having protocols on how to dress and swab these wounds is equally important. And I must admit, the South Australian Health have been very supportive in helping me develop a protocol in South Australia to dress these wounds if we do have any in our services. So appreciate that it's actually on the radar here today. Thank you.
Thank you, and thank you for those insights. You know, and just that issue on the wounds. You know, sores are common, and if people don't think, okay, I need to swab this, and I need to ask for diphtheria as being one of the possible differentials that gets tested, we will be missing cases, particularly in vulnerable communities. So thank you for raising that, and thank you for the extraordinary work that you're doing with your colleagues there in South Australia and around the country. Thank you.
Do you want to stay up here?
Okay. Mm-hmm.